Okay, I think we can make a start. So good morning or good afternoon for everybody. Welcome to today's workshop on implementation of novel laboratory diagnostics for emerging infectious disease. This event is brought to you by Pandora, ComTom, Alert, Fiocruz, Haiti, and Global Health Network. My name is Leah. I'm a postdoc at UCL and I work for Pandora, and I'm delighted to be joined today with you and excellent speakers. We had a great first day yesterday, brilliantly chaired by Isabel. Thank you, Isabel. And today we will have 3 sessions. The first talk will be on verification, validation, and evaluation for novel diagnostics, followed by a talk on quality assurance, quality control during emergency response. And after the break, we will have an interactive session where you have the opportunity to get closer to other attendees and the speakers. I hope you enjoy it. I would like to begin the program of today. Firstly, I would like to welcome Dr. Jackie Duggan, who is a principal scientist at the Public Health England in the Rare and Imported Pathogens Laboratory. Her experience spans a number of subjects, including new and emerging disease threats, biological defense, laboratory automation and robotics, vaccine development, and novel diagnostics. In particular, Jackie has an interest in the development of multiplex assays, and has developed a Tachman array card with the capability of detecting 50 bacteria and viral pathogens that cause disease, including respiratory, gastrointestinal, and high consequence infections in Africa. She's also involved in projects to improve laboratory and diagnostics capacity for anthrax in low and middle income countries. Recently, Jack has been acting as a scientific advisor to the UK Department of Health and Social Care to advise on diagnostics tests for SARS-CoV-2. We are pleased to have you here, Jackie. Thank you very much for accepting this invitation, and please, let's learn from Jackie.
Yes, thank you very much for the introduction, and thank you very much for inviting me to talk here today. Okay, so good afternoon, everyone, or good morning or good evening, depending where you are. I'm going to be talking on validation, verification, and evaluation of new diagnostic assays today, and Tim Brooks will be available to help with the Q&A session afterwards. Next slide, please. So this is an overview of the presentation today. I'm going to give you a brief introduction to our department, RIPL. Then I'm going to talk briefly about some diagnostic technologies. A lot of this was covered yesterday, but it's really just a reminder. I'm going to go through the definitions for validation, verification, and evaluation. And then I'm going to go through the steps for conducting a validation. We're an imported pathogens laboratory. This provides a UK diagnostic service for a wide range of pathogens. We provide specialist expertise and advice to clinical, veterinary, and environmental services throughout the UK, Europe, and the rest of the world. We are a WHO collaborating centre. Sorry, the slides are going a bit, thank you. We are a WHO collaborating centre for virus reference and research for special pathogens, and also a WHO reference laboratory for Bacillus anthracis. Next slide, please. So these are the pathogens that we cover as part of our service. We cover the major biothreat agents, including anthrax, Burkholderia pseudobalii, Coxiella, Francisella. And we also cover a range of vector-borne bacteria, including Borrelia, Anaplasma, Rickettsia. And also recently, we offer service for Leptospira and Bartonella, and we're constantly expanding our services. For viruses, we cover all the arboviruses, including alphaviruses, flaviviruses, and bunniviruses, and VHS and other dangerous viruses, including filoviruses, arenaviruses, poxviruses, hantaviruses, and also henipaviruses. Next slide, please. So there are many diagnostic technologies that are now available. Some of these are laboratory-based, and these include PCR, And increasingly now, multiplex PCR and technology such as TaqBan array cards that can detect many different pathogens at once. LAMP is becoming more and more popular. That can be extracted or direct LAMP. And we find in particular that serology is still very much an important part of the diagnostic process, particularly since quite often by the time we get the sample, the pathogen is no longer available. So we need to look for the antibody response. And there are many, many different types of technologies in serology, including ELISA and IFA. Culture is still very much important and is still the gold standard, and also microscopy. And there are many different types of microscopy and staining methods that are still in use. Increasingly, point of care technology is becoming more important, and the number of technologies covering point of care are growing daily. Probably the most simplest is lateral flow technology, which can be used with or without readers. There are a number of point of care LAMP equipment available, including the Optogene and the Abbott ID Now. Rapid and portable PCR is also growing in importance, and these include the Molbio TrueNat and the DRW Samba. Biomarkers are a growing field within point of care, and I've pointed out here the February DX. This is a finger prick lateral flow assay that detects two biomarkers in the blood and is able to distinguish between virus and bacterial infections, and is being increasingly used at primary care to stop the over use of antibiotics. Newer technologies that are increasingly being developed are things like breath testing, and also I've included here holographic microscopy. This is actually using technology that's used to look at distant star systems, and in this case, it's actually used to look at the molecular structure of the binding domain of SARS-CoV-2 in a system called the IABRA Virulens, and this has been trialled at Heathrow Airport in London. Next slide, please. So going through the definitions, for validation, the ISO 15189 regulations, which cover diagnostic assays, says that validation is the confirmation through the provision of objective evidence that the requirements for a specific intended use or application has been fulfilled. And it examines the whole process from start to finish of a diagnostic test to make sure that the results are correct and consistent. A validation should be performed for any new method or instrumentation that you introduce in your laboratory, where there have been major changes to an original validation, where the performance of the existing methods that you've been using have been shown to be unsatisfactory, or when a method is changed or modified beyond the original specification. And this is called off-label use. Next slide, please. So according to ISO 15189, verification is the confirmation through the provision of objective evidence that specified requirements have been fulfilled. The purpose is to confirm whether or not a product, which could be a validated method, a commercial kit system, or an equipment, complies with a regulation requirement, specification, or an imposed condition. Verification can be used when a new validated commercial assay or equipment comes with a very defined set of performance criteria. So basically a full validation carried out by someone else, in which case you only really need to carry out a verification to make sure that it meets those requirements. Next slide, please. Evaluation is the measurement of the performance of capabilities of a system or test method. And examples of these include a comparison of similar test methodologies to determine a performance against one another, and that's a head-to-head comparison. Or it could be a comparison of different methodologies that are designed to detect the same marker or target, for example, PCR or LAMP. And also a comparison of different equipment with the same function, for example, PCR thermocyclers. Next slide, please. So this shows a flow chart of when to use validation, verification, or evaluation. Validation should be used for non-standard methods, in-house laboratory designed and developed methods, the standard method that's used outside the existing scope, or a modified validated method. And it defines performance characteristics as extensive as is necessary to confirm through the provision of objective evidence that the specific requirements have been fulfilled. Verification can be used when existing validated methods with defined characteristics exist. and also after minor modification of a method. And this compares the performance characteristics with the specifications. It can also be used to review assay performance periodically or when problems arise. An evaluation compares a new method against existing methods or can compare similar assays. And it's used to compare performance characteristics with specifications of already existing methods. Next slide, please. So these are the different steps in technical validation. And I'll talk through each of these over the next few slides. Next slide, please. Sample types. What sample type do you need to use? The sample type can quite often be recommended in the instructions for use, although it's often worth validating multiple sample types, depending on the type of assay that you're using. And you also need to think about how many positive and negative samples you're going to need for your evaluation or validation. So you need to use a statistical sample size that gives sufficient power to meet all its objectives. The sample number should include positive samples in the low, mid, and high ranges, as well as negative samples. Confounder samples, such as those in the differential diagnosis for that particular disease, and those containing inhibitors for that particular sample type, should be included in the negative sample set. And then equipment and reagents. What else do you need to run the assay, and have you got what is required? Next slide, please. So the actual sample type is actually very important because you can only actually detect what is in that particular sample. And so the sample must be relevant to the disease, and you need to have as many relevant sample types as possible. Bacteria and viruses may be present in multiple sample types, and they may persist in tissue and fluid when they are not in the blood. And we are finding increasingly that urine is a very good sample type, because when we can't find the pathogen in the blood, we can quite often still find it in the urine. The pathogen may also be excreted in fluids after recovery, such as Ebola and Zika in semen, and CCHF in urine up to 30 days after infection. And the right-hand column shows the many, many different types of samples that are available. Next slide, please. So analytical sensitivity and specificity. So this is looking at how the assay performs within quite strict criteria within the laboratory. So analytical sensitivity starts with a dilution series. And for this, you need validated sample types or positive control material. We recommend using 5 replicates of positive samples and 5 replicates of negative samples, although this figure may vary. For the positive samples, these should be diluted 5 times with log 10 dilution, and each of the dilutions, replicates of each dilution tested. To get the linearity of the assay, then you plot the data from the dilution series, and this should approximate to a straight line. And an example is shown in the right-hand corner. The lowest limits of detection is the lowest dilution or concentration that can detect more than 95% of the positive samples. And this should also be determined. Analytical specificity, this is looking at the specificity of the assays for cross-reaction to non-target samples and organisms. This should include a large range of different samples and organisms, and also should include positive reference material, which are widely available from companies such as ATCC and Septomatrix. And it should also look at interferences with known inhibitors depending on the sample type. Next slide, please. So then you should go on to look for precision and robustness of the assay. Precision is how the variation in the assay and how precise the assay is from day to day. Intra-assay precision, so we recommend 5 replicate values over the dynamic range of the assay, so that means that high, middle, and low positive values tested on a single day. And also negative samples should be included in that as well. So the standard deviation for the values should be determined and the coefficient of variation calculated. This should ideally be under 5%, which shows that there is limited variation between the samples. Inter-assay precision is as above, but testing replicate value should be from different days. So for assay robustness, there's repeatability, which is spiking negative samples with a known amount of clinical or positive material. And we would recommend 3 times the lowest limit of detection, all of which should be positive. And the reproducibility, which is the ability to produce the same diagnostic result under many different conditions. And this can include different operators, different test batches, apparatus, different laboratories, and different intervals of time. Next slide, please. Uncertainty of measurement is when there's a manual measurement step, and depending on the operator, the values from the measurements can vary. So this can include activities such as measuring antimicrobial zone sizes, microscopy, looking for microscopy on fluids, organism counts, and scoring IFA slides. Anything that requires a manual measurement needs a measurement uncertainty of measurement evaluation. Next slide, please. So diagnostic sensitivity and specificity is important across both validation, verification, and evaluation, and should be included in all of those activities, regardless of which one you're doing. So the diagnostic sensitivity is the ability of the assay to correctly identify true positives, and is compared to a reference gold standard method such as PCR or culture. And the diagnostic specificity is the ability of an assay to correctly identify true negatives from the reference gold standard method. This table is a standard table that's used to determine sensitivity and specificity. So the sensitivity is A divided by A plus C, and the specificity is D divided by B plus D. Next slide, please. So positive and negative predictive values. The positive predictive value is a probability that when a sample is positive, it actually does contain the designated pathogen. And using the table from the previous slide, the positive prediction value is A divided by A plus B. The negative predictive value is a probability that when a sample is negative, it does not contain the designated pathogen. And the negative predictive value is calculated as D divided by D plus C. These predictive values are population dependent and are very much affected by prevalence rates in different populations. For example, in the UK currently, anyone can request a lateral flow test for COVID-19 and test themselves at home, which they then report their results. When the prevalence rate for COVID-19 is very low, which it is at the moment in the UK, this results in a higher rate of false positive results. This results in more people having to go forward for PCR confirmation testing and also self-isolate at home. So there does come a point when the positive prediction value means that a test is no longer of any benefit. Next slide, please. So what do you do when positive samples for your test are very rare, because the disease itself is very rare, or it is just not prevalent in high enough numbers in your country? Well, there's a number of things you can do. The first is look for positive control material, and this is widely available from different sources. So in the UK, we have the National Institute of Biological Standards and Control that produce positive control materials and panels. In the United States, BEI are a source of reagents there. And there's also WHO collaborating and reference centres that might have samples that they can share. Or you can look to use contrived samples, and this is generally made from cultured material. However, there are a number of questions you need to ask, such as, does the material need inactivation? Which for SARS-CoV-2, the answer is yes. And then by what method to maintain the integrity of the cultured material? And will inactivation affect the performance of the assay? Certainly in our experience, inactivated material does not work well in some lateral flow assays that require instrumentation to read the assays. And for spiking samples, you need a collection of different sample types to be able to spike the positive control material into this to produce your samples. There are a number of commercially sourced products such as blood, serum and urine available, and there are numerous biobanks around the world as well. You can use residual negative samples from your laboratory, although there may be other undiagnosed pathogens in that sample which might affect the assay. And you could also ask for volunteers from those in your institute, although ethical consent would be required for this. Next slide, please. So documentation. So for any validation, verification or evaluation, a report should be written with all the information and data from the validation or verification or evaluation. All the documents related to the validation, verification or evaluation should be filed in a retrievable and auditable way. And you may find that you need extra documentation such as manufacturer's instructions for use, relevant standard operating procedures. For any in-house developed assays, you will need the research and development reports, and also any evidence of the use of the assay in other laboratories. Next slide, please. I'm not going to dwell too much on this because I know that the talk next will focus on quality control. Really, just explain what these are. So internal quality assessment. These are when clinical specimens are regularly and anonymously reintroduced back into the diagnostic workflow, and this monitors the performance of the staff conducting the assays and also test procedures. Internal quality control is a daily quality control using samples that closely match patient samples as possible. These should be plotted on a daily basis and should produce a horizontal line. And if the line deviates from the horizontal, it's usually due to a sudden or gradual shift in performance. An external quality assessment is an interlaboratory comparison organised by external quality assessment schemes. There are many of these schemes available. Some examples are given here. Next question, please. Next slide, please. So I'm just going to give you some information based on our experience of validation of SARS-CoV-2 diagnostic assays in England. So in England, diagnostic testing is carried out within the National Health Service, and the UK government have been overwhelmed with offers from diagnostic companies to use their assays. The validation of these assays has been overseen by two groups, the Technologies Validation Group and the Lateral Flow Validation Group. Any assays submitted for validation undergo at first a scientific desktop review, and this is reviewed against very strict performance criteria and does help to weed out quite a lot of the assays that have been offered. If they pass the scientific desktop review, they then go into validation in a number of laboratories where they are tested against 150 RT-PCR positive samples and 250 RT-PCR negative samples. And they also receive a full validation as just described. So there are many lessons that we've learned. I think these are the most important ones here. The first is to liaise closely with the manufacturer, particularly for new technologies. We have been looking at technology that's really still under development, and when we've put these into real world scenarios in the hospitals, we found that there's particular difficulties with the technology, and the manufacturer needs to go away and carry on developing their technologies. To ensure that the assay being validated is the same as the assay to be sold on the market, we have undertaken full validations using precious samples for some products, only to be told at the end of that by the manufacturer that that's not actually the version that's going to be sold on the market because they're intending to change their buffer. And that makes the whole validation completely null and void. And be prepared for assays to perform below that stated by the manufacturer. We have looked at assays that the manufacturer has claimed has had high sensitivity, over 95%. But when we've actually looked at it in our validations, the sensitivity has been poor, generally under 80%. And in-service evaluation and usability assessment is very important. We have had some equipment that we have rolled out to hospitals that the hospitals have not been able to actually use. And so the equipment's just been consigned to the cupboard and not used. Next slide, please. So connecting diagnostics to the clinical part, are you actually asking the right question? First of all, has the patient got a particular disease? This is mostly useful in an outbreak when you know what the disease is most likely to be, and to public health people. But it's no value to the patient unless they actually have that disease. So what disease has the patient actually got? This is very helpful to the patients and the physicians. We'll give the patient an answer to what's ailing them. And it usually involves testing for a panel of agents at once. And this also helps to inform appropriate treatment and reduces inappropriate treatment, such as antibiotic treatment for viral infections. And also, has the person had a particular disease? This is useful for epidemiology, outbreak tracking, and is occasionally needed for patient management, particularly when they have a wide vaccination history. And different assay performance characteristics may be needed for each of those questions. Next slide, please. So to finish the presentation, this is the motto in our laboratory. For those of you whose Latin is a bit rusty, that means always take the piss, because it is a very, very good sample type. Thank you for your attention.
Thank you very much, Jackie. This was a very interesting lecture, and I think we can open for the questions. I got here a question from Feleke Demeke, who is asking, what is the sensitivity and specificity of holographic microscopy compared to conventional or other fluorescent microscopy techniques, and for which microorganisms it is recommended?
Well, at the moment, they have a SARS-CoV-2 assay available. I don't know if they have any other assays available. And in our hands, we found the sensitivity is less than PCR, but better than lateral flow. So it falls within the sort of 70 to 90% range.
Thank you. A question from Marlene Renderos. Can we use samples that have been proved with another assay? I think she means that if you have a sample and then you test it using another assay, if you can use it to perform, to use it as a positive control or negative controls to validation, verification, evaluation. I think that's what she means.
If it's been shown with to work with another assay, then I would say yes, you will be able to use that as a control material.
Thank you. And she's also asking, how many samples do you recommend as a minimum for a verification? I think, if I am not mistaken, you have to do some calculations to infer that. I think that's what she's asking about.
Yes, that's right. So it would depend on the calculation of your sample size. For SARS-CoV-2 verifications, we're using 30-30, so 30 positives and 30 negatives.
Thank you. And Soafai is asking, what's the difference between coefficient of variation and standard deviation?
I think I might need to ask Tim's help for this one. So the coefficient of variation, that's just the extent to which the values differ for each sample set that's being tested. Whereas the standard deviation is a standard deviation for that particular value.
This Tim?
So both of those are measures of variability. Usually you use the coefficient of variation to express how tight an assay is from time to time. The standard deviation, as Jackie says, is the variation around a mean that your assays have. That's quite useful for setting your limits. We usually say plus or minus 3 standard deviations is the range in which a reference sample should fall if you test it repeatedly. But the smaller the tighter the coefficient of variation, then the more likely it is that those limits will be nice and close. And if you do the sample, do two different samples in different dilutions, you will be able to discriminate between them. If you've got too wide a coefficient of variation or too wide a standard deviation, then your assay may have very great difficulty in discriminating between samples which have a low value and others that have a much higher value. So all of those things are important. Does that help?
Sorry, yeah, please continue.
I think I said it.
Thank you very much. So Neka, I'm sorry, I think I'm going to say it wrong, but Neka Onibeju is asking, what do you advise for validation purposes when there is no defining gold standard, especially in the context of COVID-19? I think this is a very interesting question. We just faced it and right now. So yeah.
Okay. It is an extremely interesting question, because if you haven't got a gold standard, then you can't compare your new assay against anything else. It's even more complicated if the gold standard you have isn't as good as the assay you now have. So you have to try and pull together a whole lot of different pieces of information to try and convince yourself and the other people around you that you are finding what you look for. One way of doing it is, if you have several different methods of identifying an organism, is to use them all and then try and compare between them which one is giving you the best sensitivity. So if you were trying to develop a new assay, you could look at developing a PCR for the pathogen if you had the pathogen, and you could do some sequencing on it. When you get a positive in the clinical material, you can then take that positive sample and go back and do some sequencing and see if it correlates with the sequence of the organism if you knew it. It becomes much more difficult if you're trying to do a serological test, but what you can do is gain increasing amounts of assurance, so that if you have a whole range of patients who present with the same set of symptoms, this serological test works in them all. And if you have been able to obtain the pathogen, and at the same time, you have been able to obtain serological samples, so that with a PCR or some other method to prove the pathogen's there, you can then say that your antibody test, if it's picking up antibodies to that pathogen, is picking up the right thing. But in doing that, you also have to run a whole range of other diseases that you know about that co-circulate with that or are present in the same endemic region to ensure that it isn't picking up those. Finally, if you have several different tests, you can run them all in different ways upon those same sets of samples or more than one set of samples, and then use a system called Bayesian statistics to try and work it to what disease you've got and what the performance of those tests are. So to do that, you could compare 3 different tests, all looking for the same organism, and with the Bayesian system, it will calculate for you what a gold standard would look like and which of your tests is nearest to it. But it's a very complicated method to do it. And really, ultimately, it's iterative, trying to use all the pieces of evidence that you have to give you more and more assurance against that your test is finding the right thing. We see this quite a lot of problems nowadays, in that PCR is much more sensitive than some of the culture methods, and culture is seen as the gold standard. And it is therefore an ongoing argument. If you find something by a PCR and you can't culture it, whether it's actually there. I think nowadays we believe that it is, but you can never be sure with any method that it's finding all the possibilities. And you have to, I think, at some point, accept that what you've got is as good as it can get. So long as it's fit for purpose, you can identify those people who present with that disease, and you can find some evidence independently. They can culture the organism, or you can PCR the organism and sequence it, so that you get a continuing amount of data that it is referring to a unique entity. A complicated thing to do.
Thank you. Would you have anything to add?
I'm sorry?
Jackie has anything to add?
Yes, I'd just like to say that for the example of SARS-CoV-2, we generally used a CE marked PCR assay from I would say a reputable manufacturer as the gold standards in our validations.
So it's a lot easier when we have a test somewhere. A lot harder when it first appears. Nobody has a test.
Yeah, thank you. So moving forward to other questions. So Godfrey Tuda has asked, please, he asked to share the formula for calculating uncertainty of measurement. If you could, maybe you can place that on the chat box later. And Neka Onipeju again is asking, what is the outcome in situations where assay performed below that is stated by the manufacturer? Oh, I think she means that what is the outcome in situations where the assay perform below what is stated by the manufacturer?
That's pretty nearly all of them. Very, very frequently, the manufacturers have used a defined set of materials to come up with those numbers. And for obvious reasons, they're keen to present it in the best data. When we've run sample studies using significant numbers of samples, several hundred, 900, 1,000, or even 1,200 samples, then you don't normally achieve the same results that the manufacturers achieve. And when you put that assay out into the real world, so that it's used widely in service, we find exactly the same effect. And the reasons are quite complicated, but they depend, particularly for a new disease, on the sample set that was available in which the testing was originally done. So that if you were to be looking at a PCR test and you get samples at the very peak of the disease when the level of virus or bacteria is at its highest, then you're going to have very different results in terms of sensitivity than if you look later in the disease when the concentration of those organisms has fallen. If you try and do an antibody test before the antibodies have developed fully, you'll have a much worse sensitivity than if you look at peak period about 6 weeks after the onset of the disease, when the rate of seroconversion is much higher. So there's also the balance between sensitivity and specificity. And to determine that, then the manufacturers will have used a system called a receiver operating characteristic graph, in which they try to achieve the best possible balance between sensitivity and specificity. And if you were to plot sensitivity against specificity, what you really want is to have 100% sensitivity and 100% specificity, but you never get that. And so each manufacturer will adapt their assay to give what they see as being the best combination between the two. And that depends a bit on what you're going to use your assay for. If you're using a screening assay, you want very, very high sensitivity, and you might be prepared to sacrifice the specificity because you'd use a confirmation assay. If you want to prove beyond all reasonable doubt that somebody has a specific disease, then you want to go the other way around. You want very high specificity, and you may be prepared, you may have to sacrifice some sensitivity in doing that. So it's always a trade-off. It's never perfect. It depends on your sample set. Worse still, it probably depends on your geographical location and the levels of background diseases in your population. And it depends on how widely you look across the range of time courses for the disease and the circumstances in which you're using it. Not an easy question to solve for the manufacturer or for those of us using the tests.
Yeah, indeed. And so I've heard about a situation where the regulatory agency was having problem with COVID testing now, because people are getting tested after vaccination to see if the vaccination is working, and the manufacturers cannot say anything about that because the thresholds are not for that purpose. And it's been very complicated. At least this is a situation that I've heard from Brazil, but I believe that in other places.
That's actually really hard. If you want to know whether the vaccine is working, it depends what you're trying to look for. It's not too difficult to find out if somebody's responded to a vaccine, but we don't at the moment have any assay that can tell you whether the level of antibody you've produced is enough to guarantee protection. And that's a very, very different question. It would depend on the assay you're using. It also depends on us knowing exactly what parts of an immune response you need to be immune. So it's very unlikely that we're going to be able to do that simply with just a single parameter, but we may be able to.
Thank you. Jackie, do you have anything to add on to this whole discussion?
No, I think Tim's doing a fine job.
To nail it.
She did all the hard work writing all the talk.
Yeah, great. Thank you very much, you both. I think we don't have any questions for the moment, but I would invite you to stay as long as you can, and we can go back to those questions. So the participants can still posting questions on the chat box, and then we can come back on the questions after the second section. Thank you. So now we will be moving forward to our event, and I would like to introduce you to Dr. Collins Otieno for the next section. Collins is a very experienced scientist who holds a PhD in medical virology and is currently the project lead for the Laboratory Systems Strengthening Community of Practice, a project called LabCop. And this project is being developed by the African Society for Laboratory Medicine. LabCop fosters a knowledge exchange and joint learning by linking together country teams and global experts and sharing the knowledge and best practices on virologic scale-up and lab systems strengthening amongst ministries of health. Collins is also the editor for the ASLM Lab Culture magazine for laboratory medicine that includes features on critical aspects for laboratory medicine and best practice in resource-limiting settings. Thank you, Collins, for accepting our invitation to share your knowledge here, and you have the floor.
Thank you, Leah, for that introduction. And I must thank the previous speakers, Jackie, and also Tim, who helped with the questions, some of which overlap with what I'm about to present. Yeah, just to tell you more about the African Society for Laboratory Medicine. It's a Pan-African organization with a mission to improve clinical and public health outcomes in Africa by enhancing professional laboratory practice, science, and networks. We operate under 5 pillars. The first pillar is laboratory networks. The second is workforce development. The third is quality of laboratory services. The fourth is regulatory systems. And the fifth is communication and knowledge management. So I'll give you a talk on quality assurance and quality control during an emergency response. And we are basing it on the COVID-19, our experience on the COVID-19 in the African continent. So the outline of my talk will be an introduction. Then I'll talk about quality assurance, quality control, external quality assessment, quality improvement, and then I will summarize. So as a way of introduction, we know that the coronavirus disease 2019, COVID-19, is now a pandemic and has spread to most of the globe. In Africa, the first case was reported in Egypt in February 2020. And at that time, there were only 2 laboratories who could test SARS-CoV-2, the causative agent of COVID-19. And so there was a concerted African response, whereby training was offered to more country reference labs. And by May, there were 43 countries who had the capability to do the test. It's also important to detect the virus early so that we can limit its transmission, and also to ensure that we can effect some of the measures that, like isolation and quarantine, to prevent local spread, and also to inform other interventions. The lab plays a critical role in detection of SARS-CoV-2, and so the lab routinely confirms infections and also can be mobilized to outbreak places to identify the cause of an outbreak. For SARS-CoV-2, the molecular assay on nasopharyngeal swab is the gold standard and is the most commonly used and reliable test. Although now there are antigen tests that are being distributed within the African continent to meet the testing needs of those countries. As been alluded to, most of these assays have a high specificity, and this is because they are primers that are targeted towards some gene sequences. However, their sensitivities may differ based on the quality of specimen. Also, as mentioned, the sampling time during the onset of symptoms. There could be testing errors or other technical deficiencies. So as such, there is possibility to have false positives and false negative results that may have negative implications for containment of the disease. It is therefore critical to implement quality assurance measures to ensure that the results the laboratories are producing are reliable and acceptable. So what is quality assurance? So this is part of the quality management system that focuses on providing confidence that we are fulfilling the requirements of the quality management system. So the system is designed to allow us to continuously improve the reliability and the efficiency of the laboratory tests that are conducted to identify this cause or to do diagnosis. And the aim of quality assurance is mainly to minimize the error rates at the different stages in the laboratory testing cascade, right from the pre-analytical phase before the samples reach the lab, during testing, which is the analytical phase, and also the post-analytical phase where we share out the results. So this figure is a summary of the activities under quality assurance. And quality assurance encompasses issues to do with safety of the laboratory personnel testing. It involves quality control, which we'll see in more detail. It involves external quality assessment that has 3 arms, which are site visits, also called on-site mentorship, retesting, and proficiency testing, also known as PT. It also encompasses good record keeping, as has been mentioned, so that results can be tracked right from the date they have been collected, how they were transported, all the way to when results are released, and other activities within the lab. So the entire cascade, there are a lot of areas where issues can occur, right from the clinic where a swab is drawn. There could be wrong sample collection, and during transport, there's likely to be RNA degradation if not transported properly. And even during extraction, there are problems that could occur like nucleic acid contamination and even degradation by nucleases. When you prepare your master mix, that's another place where we can have errors. The reagents could be expired. They could be mixed in the wrong amounts. And you could end up also using nucleic acid that's contaminated within the assay. Then when you run the one-step RT-PCR, you could also use the wrong cycles for PCR, and that can also lead to wrong interpretation of results, depending on what you have. And so we know with a new disease like COVID-19, we are faced with a lot of challenges. Yeah, like one, we don't have the testing kits, and there's a waiver by countries to allow testing using equipment that have been fast-tracked through the approval process. And as such, we have to understand these challenges. There's also little performance data available for these tests because they were rushed through the approval process to respond to the emergency. As has been alluded to in the previous presentation, we also could be faced with a challenge of getting positive control material that can be used for method evaluation studies. So ASLM, the African CDC, and other partners recognizing the gap in quality assurance and quality control developed guidance documents to help the African countries as they scale up testing for COVID-19. The guidance range from pooled testing because of the lockdowns that were implemented. Countries were asking if they could pool samples so that they use the little available reagents to ensure that maximum testing is done. There were also guidance documents on quality assurance for molecular assay that was produced by FIND, Africa CDC, and ASLM. We also developed best practices cookbook that guides what are the quality assurance issues that must be addressed all through the quality management systems, starting from sample collection to release of results. In an effort to disseminate this information, we also established webinars and talks by subject matter experts using the ECHO platform through our LabCorp project. And to date, we have been able to conduct 35 of such sessions. We invited manufacturers of this equipment to come and interact with users so that they can tell them more about the additional studies that they have done to ensure that these results meet the required sensitivities and specificities. And then we hope that with this knowledge, countries would then make a better choice of what equipment or test assays they could select. We also brought in technical agencies like the WHO and Africa CDC, and to give guidance on specific aspects of quality assurance of COVID-19 tests. And we also invited countries, the United States and South Korea, to give their country experience on what they were able to do to minimize the spread of the COVID-19. Through our Resolve for Life project for COVID-19 testing scale-up, we are able to establish a WhatsApp platform for member countries where they will be able to interact and answer those key questions that countries had that needed immediate response. To expand the reach of these guidance documents, they are also translated into French and Portuguese so that those other countries can as well benefit. So what is quality control? So quality control is a material or mechanism used to monitor the analytical performance of a test, whether it's used as part of it or within the test system. quality control, they monitor the entire test system or only one aspect of the test, and it allows us to validate the competency of testing labs by assessing sample quality, monitoring our procedures, kits, and also the instruments against some established criteria. And quality control, as has been mentioned, also requires good record keeping. So what are the QC testing events within the COVID testing? So this could be included during method evaluation, as has been presented before, when checking instrument integrity, before patient testing, or when you receive new test shipments. So you need to do a lot-to-lot validation to ensure that that new lot operates the same as the old lot that a lab has been using, and also used to train new test operators before they start testing. So the common controls used in COVID-19 include an extraction control, which is used to demonstrate successful recovery of RNA and also to test the integrity of the extraction reagents. And this is usually employed within each run that is done for a batch of samples. The other control is the no template control that is used to check contamination during the specimen extraction process and also when setting up the plate for PCR. To notice that if this no template control reacts positive, then it demonstrates that there's contamination and the test has to be abandoned. A repeat testing can then be done, but this time ensuring that there's strict adherence to the standard operation procedures. It also indicates that PCR reagents may have been contaminated as well. The other control is a positive control, and this is an in vitro transcribed SARS-CoV-2 RNA. So it could be a gene fragment or a whole genome of the virus. It indicates the limit of detection and also the robustness of the assay we are conducting. And it should be handled with caution in the clean room where we avoid contamination. The next is external quality assessment, which is the process that allows labs to assess their performance by comparing their results with other peer labs. This can be through panel testing and also through sample retesting. So it evaluates the competency of the testers, the performance of the lab, reliability of the test method, accuracy of our results, and also there's a follow-up of those non-conformances that result in a failure in the EQA scheme. So there are three main methods that I use: the proficiency testing, the retesting, and on-site evaluation. So proficiency testing is whereby an EQA provider prepares a sample for PT panels. Those panels are then shipped to participating laboratories who then conduct the test and report their results. These results are then statistically analyzed by the EQA provider, who then prepares the report and sends back the report to the countries, whether they have passed or failed. For those who have failed, they have to address the non-conformance that resulted in the failure. They have to identify that. So as part of the quality assessment in reference labs, the WHO has supported 45 countries and 178 labs in these 45 countries through the WHO EQAP. So ASLM also synergize their activity to support those facilities where decentralization of testing was taken. So the lower health facilities below the reference lab, as you can see in the left panel. This was done for 355 labs in 23 countries. And working with one of the EQA providers, we are able to deliver PT panels to these countries, and used a dashboard that was established for the continent to measure the success or failure of this PT panel performance. There were 2 rounds that were given by the time we prepared this presentation, and most labs that participated had passed. So the other method is sample retesting. This involves taking samples that have been identified positive by a reference lab or one of the labs and retesting at another lab to allow that interlaboratory comparison. According to the guide by WHO, the first positive samples for COVID-19 were to be shipped to a WHO reference laboratory. Subsequently, some of these samples could be shipped to the national laboratories that already had this capacity to test. But in the absence of PT, national labs should also send 5 positive and 10 negative samples to a WHO reference laboratory for retesting. Similarly, the lower level labs should send retesting samples to their national reference laboratories, just to ensure that they are correctly identifying the virus. So for on-site evaluation, this is performed by an experienced subject matter expert, and he travels to the facility and observes the testing right from sample collection all the way to release of results. This method, although very sensitive, was hampered by the restriction in movement and also lockdowns. So what are the challenges that the continent faced in terms of implementing quality assurance? And what are some of these possible solutions? One was the unavailability of controls. And as a mitigation measure, they were advised to use a confirmed positive patient sample for positive controls and use water or universal transport media or viral transport media for negative controls. The other challenge faced was that most methods were still under development. Hence, there was no validation data or use in field settings. So the countries were advised to use the methods that are listed on the WHO, FDA, or CE marked emergency use equipment or tests, and also rely on third-party evaluations that were conducted by organizations such as FIND. The other challenge was unavailability of EQA schemes, and countries were advised to develop interlaboratory comparison and also send positive samples to their national reference or WHO reference laboratories. So in summary, in terms of the approaches, we have internal QCs, retesting, proficiency testing, and on-site mentorship. And all these approaches measure mainly 2 issues. One is to do with the technology and the system, and one is to measure the competence of the user. And for each, you can see that there are gaps, like internal control. Yeah, it will be able to evaluate the user's competence for most of the activities, but it is weak on technology and system evaluation. The same for retesting, but on-site mentorship allows one to follow through right from the time a sample is collected to the release of results. So they're able to see issues to do with the patient identification. They're able to determine if samples and reagents were stored properly, unlike the other QA approaches. So we need to employ not one, but several approaches to ensure that our tests are accurate. So we should also employ quality improvement to monitor the performance of the whole testing process. This is recommended to be done at least monthly or even more often. And we should identify indicators that are used to monitor quality, like the number of specimens tested, and also specimen type, the number of positives, negatives, and invalid test results, the rejection rates, number of failed internal quality controls, the EQA or PT performance, whether it's a pass or fail, and the score, and also turnaround time. So in summary, laboratories need to develop a structured plan for emergency testing, ensure that the safety of personnel is in place, verify the selected test methods, ensure that personnel are effectively trained to conduct these tests, ensure that sample collection, handling, and transportation is well done and QC'd, and also finally to implement the test properly by ensuring that quality controls are included, and from time to time assessing externally as well. These are a few references for you to go through, and thank you for listening.
Thank you very much, Collins. We are going to open for questions, and I would like to invite Jackie back to reply to some questions from the previous session that are a bit delayed. So for from Tinashe Niyazika to Jackie and Ting still, how best do you select samples for SARS-CoV-2 validation for antigen assay, considering that the disease has different clinical presentation?
Could you repeat the question, please?
Yes. How best do you select samples for SARS-CoV-2 validation for antigen assay, considering that the disease has different clinical presentations?
We would just choose samples that have been RT-PCR positive. So rather than go on the presentations, we've been using samples that we've known are positive through RT-PCR.
And it also depends on what question you're trying to answer, or what questions you have, what samples you have available. So if you are, for example, looking to test whether a lateral flow kit for antigens would be suitable for people to use at home, then you have to decide whether you want them to take a throat swab or a nose swab, and that's going to be a function of what you think is easiest for them to take and what the assays are available to do. So for those people, you would try to choose samples taken in the same way as you intend to use your assay. If you're looking at a PCR test that's validated for use on nasopharyngeal swabs, on nasal swabs, on saliva or throat swabs, then you need all of them, all four. If you're doing a serological assay, then you need to use samples of blood, and you want to take them across the whole range of timings related to the appearance of the immune system. So right from about day 10, and ideally before that, because they should be negative in the very early stages, right through to the time when the immune response is fully matured at about 3 months. So it very much depends on what you're trying to do, what your assay is for, and what you hope to get out of it. I think that's about it.
Thank you, Tim. Now I have asked a question for Collins. Verena Brandt asked, if you could elaborate on the graphics shown before for sample retesting. You are mute, Colin, sorry. Can you mute?
Yes, I can hear you, sorry. Yeah, so thanks for the question. So the dashboard is an easy way to collect results from the 355 laboratories. So one of the project outcomes was to develop a dashboard where all the data can be gathered in country and also across Africa to show which labs have passed, which ones have failed, and also to integrate PT. So not only for COVID-19, but for other diseases. So like HIV, we have viral load and EID PT panels as well. So this was a way to consolidate all the data so that they can be M&Ed, monitoring and evaluation, which we said is important as part of quality improvement. Thank you.
Thank you, Collins. So they are asking if you could show this graph so they could understand it better.
Okay, let me show it.
Thank you.
This one, the next one, this one. Yeah, so it's for monitoring and evaluation to monitor the indicators. So the greens are those labs that have passed the first round, this one. And then the second green is the labs that have passed in the second round. And then the red are those labs that failed, that need to implement corrective action. And then the lower graph here is PT panel at country level that shows integration of PTs for different diseases that can easily be used for monitoring. Thank you.
Thank you, Collins.
Thank you.
Another question for you. Neka Onijepu is asking if ASLM could provide EQA panels given the high cost of panels and if it is a requirement for accreditation.
No, ASLM does not provide EQA panels, but that was provided through funding through a project we have called Resolve for Life SARS-CoV-2. And yeah, so we were given funds and we worked through One World Accuracy to supply PT panels for COVID-19 for 2 rounds. Thank you.
Thank you. And and how have laboratory networks played a role in strengthening the response to COVID testing as ASLM's experience? Have the labs mentored one another? I think this is an interesting question.
Yeah. So as mentioned at the beginning, just before COVID hit the African continent, there were only 2 centers of excellence that had the capacity to identify SARS-CoV-2. That was one lab in Senegal and another one in South Africa, Johannesburg. And so through these networks and the coordination by the Africa CDC, we were able to deliver trainings to additional 41 countries to have 43 countries capable of testing by May 2020. And right now, all countries are able to detect, at least at the national level. Then within the countries, the national level labs have to decentralize testing to the lower tier laboratories so that they cover their testing need within the country. Thank you.
Thank you. And just to change a bit of the subject, a question to Tim and Jackie. So Chair Holland is congratulations for the presentations to our speakers, and he's asking if Can a mutation in SARS-CoV-2 viruses affect the results of the tests, be in RT-PCR or serological tests?
I'm just writing an answer to that one.
Yeah, the answer is yes. So this is how we detected the Kent strain in the UK, because one of the more common PCR assays used is the Thermo Fisher PCR assay. And one of the targets of that assay is the S protein. And the Kent variant had a deletion in the area where the primers bind on the S protein, on the S gene. And so we had a lot of S gene failures, a very high percentage of S gene failures in our test, and that showed us that there was a problem. And then when we sequenced, it was clear it was a variant, a mutation.
And so we have an ongoing program to look at all the different PCR tests that are available and to try and see how much they're affected by these different mutations. As Jackie's implied, we're also looking across the lateral flow tests. Now, some of those are based on the nucleoprotein, some of those are based on the S protein. The more worrying mutations in terms of the disease are those based on the spike protein, but some of the assays on that are affected, and there is a fall in sensitivity of the lateral flow antigen tests that we've seen for some manufacturers, depending on exactly which part of the nucleoprotein they are looking at or trying to detect or bind to, and consequently their performance may shift slightly. So it's an ongoing problem. As far as we're aware, nothing has been completely useless, because as Jackie said, the Thermo Fisher test happily has other targets, but there's always the possibility that a single target PCR test may miss something if there's been a mutation.
Thank you. And just still on this subject, question for me. And do you think that nowadays, based on the emergency of variants of concern, variants of interest, do you think that sequencing, worldwide sequencing program is too important, or we can still use the technologies that we had before, using the same surveillance for sequence that we had before, or we do have to increase it like broadly for not only SARS-CoV-2, but other diseases as well?
I think that sequencing is an important part of responding to this outbreak. Sequencing lets us find out what the variations are between the different viruses. It lets it keep a track on the different viruses. So there'll always be, in any viral disease, there are always mutations appear all the time. Using sequencing, though, we can actually work out from the sequence and the location of the different mutations how likely it is that tests would be affected depending on the design of the test. In other words, the target region on the genome that a PCR would look for. And also we can get a guess of how likely it is that that mutation will be, to a degree, immune to the vaccine. It could, it could evade the effect of the vaccine. So I think it's an essential part of it. And in terms of new diseases in general, and sequencing is an essential part nowadays of identifying the organisms in the first place, and again, following the evolution of that organism and any changes within it. It's also possible that using sequencing in the future, it's very difficult to do at the moment, you may be able to see whether it is becoming more or less likely to spread, more or less likely to affect humans. But at the moment, I don't think that we can get a sequence of a virus at the moment and say for sure that this could transfer from one species to another or not. But that will come.
Thank you. Okay, so I'll move back to Collins, questions to Collins. Someone is asking, with the LabCob sessions, about the LabCob sessions that you mentioned, were these hosted in person? And if not, if they were online, did those sessions include practical demonstrations and simulations remotely?
No, so these were the echo sessions were interactive virtual sessions. So for the trainees of the initial trainees of country reference labs for 41 countries, we organized virtual session with the trainers, and they came up with questions that they had from the difficulties they were having in implementing the tests within their regions. But initially there was a face-to-face training for countries. There were two sets. The Francophone countries went to Senegal, the Anglophone countries went to South Africa. And then we had the webinar sessions now to fine-tune the issues that they had. And then we also invited manufacturers to talk about their assays through virtual sessions where there was question and answer to address any issues. Thank you.
Thank you. And another question for you. Is there any mentorship program for labs who did not pass in IQA cycles, or what was your experience with these labs?
Yes, there was a big mentorship scheme that was offered to the labs. For each of the countries, we had a staff stationed there who was supposed to coordinate the arrival of these PTs and also the testing. So they were on site to offer mentorship. Surprisingly, for those labs that failed, some of the reasons, were like the batch of PT got lost because, travel was very difficult during that time. So not all of them failed as such, but they are recorded as failed because they didn't return a result, given that there were some challenges in delivery. Thank you.
Thank you. Yeah, I'm very happy to know all these resources that ASLM can provide, and I hope we can have you on board in other workshops in the future as well.
That's fine. Thank you.
Thank you. Okay, so please, attendees, do you have any other questions that we could address? We are a bit ahead of time, so you could use this time for questions for the panelists. Verena Brand is asking, where are the resources available? Where they find?
They are posted on our website, aslm.org.
Thank you.
Yeah. Actually, when you look at the PowerPoint presentation at the end, when you click on the resource page, you'll get other resources apart from those QA documents.
If you could post on the chat the website that you mentioned, I think it would be very helpful.
Okay.
Thank you.
Let me do that.
Okay, so if we don't have any more questions, I think we can move to the break, and then we can come back. Okay, what role does ASLM in Splinter?
Thanks, Ken. Yeah, so we play a big role in Slipter and not Slumter. Slumter is different. Yeah, so Slipter, we are the one designated to coordinate by the WHO in Africa. So we used to offer trainings and also do assessment of labs for accreditation.
And if you could post what those abbreviations mean on the chat box, I think
the Slipter
you appreciate.
So the Slipter is a stepwise laboratory implementation program towards accreditation.
That's it. So the participants are very interested in making more questions. That's great. So I have a question from Lydia, and she's asking, do you have a genomic surveillance network to identify and track variants in Africa? Do you know, so is ASLM coordinating any of surveillance for that?
Yes, we are working with Africa CDC. There's a network of laboratories in Nigeria, Senegal, and South Africa that are doing the testing. But there's also money provided by the Gates Foundation to bring on board more laboratories within the country by establishing their capacity to test. So there's a network that does this. Thanks.
Thank you. I think this covers a bit of another question that Verena asked, asking how can you collaborate and how can you work together using ASLM platform?
Yeah, so I think we can bring in our management and we can discuss further how to collaborate. I think collaborations are welcome.
And she's very interested in this topic. Verena is asking a lot of questions. Thank you, Verena, for your interest. And she's asking, how could you engage beyond Africa with with your organization?
Yeah, we only work in Africa. I know. Yeah, we've worked in Haiti, I think, and Dominican Republic for SLIPTA, but most of our work is within the African continent. But as I said, that's a decision that the management can make. So further discussion with them would be beneficial.
Yes, I think we can ask Verena to ask the questions herself. Would you like to do so, Verena? Do you have any other questions to colleagues, please?
Okay.
Hi.
I just interested in how you established the program. From like what is the history, like how you established it, and then how you started to work together.
So the establishment of ASLM. Oh, you'll have to talk to the people who were there before me. So yeah, I'm just 2 years old, so I cannot give you most of the information, but our CEO has been there from the beginning. So I suggest that we can follow up by email and I can link you up and then we have further discussions on collaboration.
Thank you so much.
That's great. Thank you, Colin. And another question to Collins, which so Nema again is asking, could you please elaborate a bit on interlaboratory reproducibility?
Yeah, so as I mentioned, comparison. This is usually so like labs within a region, within the country, can human samples to test their performance, see if they're getting the same result as for those who they institute corrective action. So it's like which comes from the laboratories that come together as peers.
Thank you, Collins. Another question is, one of the challenges. One of the challenges of in COVID-19 diagnostics is the accessibility for testing, especially for rural inhabitants. And how does the implementation status of sample referral networks across Africa countries? How much is it effective? And if there is an established system?
Yeah, so Yeah, so for testing within the rural areas, like I mentioned, there is a antigen testing that has been introduced to do testing at decentralized sites rather than send them to the reference laboratory. So to shorten the turnaround time and to increase access, antigen testing has been deployed. Thank you.
Thank you.